ask really good questions of your care team. And if you don't understand something, find somebody who will explain it to you and tell you everything you need to do to make an informed decision. But be vigilant, because you got a life to live, and it's a wonderful life.
Welcome to the CoachMD podcast. I'm Dr. Charles Glassman, bringing you 3 decades of experience as a physician and a coach. Join us as we navigate the maze of medical advice with real-life stories, empowering you to take charge of your health. In our That Happens segment, guests share transformative experiences, reminding us that we're all human and not just patients. So get ready for a journey into healthcare reimagined, where empowerment and discovery pave the way. Hey, it's Dr. Charles, aka CoachMD. In my over 30 years of medical practice, I made it my goal to help you create a strong mind, a healthy body, and an unshakable spirit. And in that regard, all of those matter very deeply. And the strong body is a very strong part of, an important part of that. And I know I talk a lot about the mind and the spirit on this podcast and in my writings. But look, I was a medical doctor, and most of the time people would come into my practice with some type of physical complaint. And yeah, sure enough, a lot of times the physical does, the mind and brain and spirit do influence the body. But sometimes there are physical problems where, they're just problems and you have to deal with them. And my guest today is I'm not going to say an old friend, but a long time friend, because we go way back to camp days. And Dan was actually my camper, okay, even though we're only a year or two apart. But I never really told Dan this, but I'm going to tell him this now, that I really was very grateful for him as a kid, as a teenager, because he was
Charlie,
Yeah.
hold on a second.
Yeah.
I apologize.
No problem. This
I
is
got,
cool.
yeah,
Take care of it.
I've got my dog he's going crazy. I gotta run him real quick. Hold on.
Yeah, absolutely. Go ahead. No problem. While we're waiting for Dan to come back, I'm just going to talk about who I was when I first met Dan. And that was a very insecure teenager. And I'm going to talk to Dan a little bit about how he made me feel in that regard, in a good way, a positive way. So Dan and I go way back to Camp Laurelwood in Madison, Connecticut days. And I really wanted to, one of my closest friends was a counselor there, or actually a waiter at the time. And he wanted me to go, but it was very competitive. He wanted me to be a counselor at some respects. I was 15 years old, and he wanted me to go, but it was very competitive to get a job at this camp. It was a very desirable camp. And so I kind of snuck my way in as a CIT, as a fishing counselor, because I love to fish, even though there was a whole department already set up, the nature and pioneering. So I was assigned to 14-year-olds. Okay. And I was 15. All right. So, Dan was one of those 14-year-olds or 13 or 14-year-olds. And he and his buddy Stu were so kind to me, honestly, as kind as a teenager could be to another teenager. And as I mentioned before, I was not the most secure 15-year-old, and that meant a lot, I have to say, Dan, way back when, and I really appreciate that. And even to this day, in my 60s, it's still, I still have those fond memories, and I do appreciate it. I also want to give you a plug. Dan, I've been on Dan's show. Dan has a podcast, What's Your Work Fit? And it's great. And I would recommend tuning into that podcast. Learn a lot about the changing environment in the workplace. And look, our work life affects our health life. Okay, it's all interwoven. So that is a very important part of who we are. And Dan's show does a great job at kind of sorting that all out. But getting to why I asked Dan to come on the CoachMD podcast, you know, as we get older, we're sometimes hit blindsided by things that we don't expect. And Dan had one of those experiences a couple years ago, and I asked him to come on to talk a little bit about that. And if you would, Dan, just kind of take us back to, and you'll get into what it was, but kind of tell us when it first started, when you started getting a sense that something was going wrong.
Well, before I get into that,
Yeah.
Charlie, I was really touched by what you said. I consider you like a brother, and
Yeah.
that's for people who have gone to summer camp and then many years later, go back to visit. It was one of the most glorious times of my life, and you just happen to be part of it, and I'm
Yeah.
grateful for that. I'm grateful for the time that I got to know you and got to make you my friend. So thank you
Yeah.
for that.
Yeah. Thank
So
you.
my big surprise, it was I'll take you back to this week in March 4 years ago. Now, what was about to happen in the world then? COVID.
Yeah. Yeah.
And I happened to be scheduled to be at a podcasting conference in Florida. And on this particular morning, I'm at the airport at Dulles Airport in Northern Virginia, and my phone rings. And it's my urologist. And he says, "Do you have a moment?" I said, "Well, I'm a little early to the gate, but I'm flying to Florida. What's up? Do you have the results of my biopsy for my prostate procedure?" And he goes, "Yes, I do. And I want to talk to you about that." Well, without mincing words, he basically said, I don't have any way but to be direct about this. You have prostate cancer. Now, let me say it's what I call wimpy cancer, which he had to explain to me,
Mm-hmm.
but it's cancer. And we have to pursue a treatment path. I would like to have the opportunity to be on a Zoom call with you and your wife, which kind of jarred me because
Yeah.
I was like, oh my God, Marcia's got to be on the phone for this. I can't deal with this myself. It must be far worse than he's telling me.
Right. Yeah.
But
Yeah.
well, I should say, Charlie, that it was not a total surprise. I had a strong family history.
Mm.
My grandfather, my paternal grandfather, my father, my brother Steve, and
Wow.
then I all developed prostate cancer. And you can, if you want to learn about the family history, I'm happy to get into that.
Yeah.
So I knew going into the biopsy, and what preceded the biopsy was a highfalutin um, MRI with special imaging where they could look for suspect areas within the prostate
Mm-hmm.
to biopsy. So it became much more accurate. If there was cancer, they would find it because parts of my prostate were lighting up.
Yep.
And indeed, that got them to where they needed to go.
Yeah. Yeah. Very, really important. The fact that, kind of backing up on what you said, and I just for the audience that, um, family history is definitely a risk factor for prostate cancer. As men age, um, we all, and I'll be very personal about this. I have an enlarged prostate. I have the symptoms, what are called LUTs, lower urinary tract symptoms. They're a pain in the neck. All right. But not all those symptoms, because most of the time prostate cancer is asymptomatic. You don't know you have it. Those symptoms are very common with all men who are aging, the lower urinary tract symptoms. But prostate cancer itself is not symptomatic, but
Right.
what Dan is talking about, this MRI, is very, very important to get, especially before any type of prostate biopsy, and even a biopsy with MRI guidance sometimes is even better. But what would happen in the years ago before the PSA level, which is the prostate specific antigen, which is a simple blood test that one can take. Before that, men would come to the hospital with prostate cancer all over their body. And when I was an intern back in the 80s, or actually a medical student back in the 80s, I remember on the ward was a guy who, this is before the PSA test, and he came in, he had metastatic prostate cancer. That means it spread all over his body. And it was terrible. And all they could do for him was castrate him, take off his remove his testicles, because that would take off the hormone that might have been a growth factor to his prostate cancer. So Dan went to the urologist, who was following him with his family history. And any man out there who has a family history of prostate cancer, especially a first generation direct link, or father, mother, father, or even mother who's had certain types of cancers also, but father, especially a brother who has had prostate cancer, definitely needs to be in the system and definitely needs to have close surveillance. But what Dan did, he did the right thing to get an MRI. If you're told by your doctor that you have an elevated PSA, you have to go to the urologist, and the urologist jumps right to a biopsy. That's not the right thing. Question the urologist, say, can we look further? Can we get an MRI? So anyway, you had that, and you had the biopsy, and he said it was a wimpy cancer. Did he give you a score? Was it the
Right.
with
Get
that?
into
Yeah.
get into that.
Okay.
I just want to
Yeah.
add another layer
Yes,
of
please.
perspective to this.
Yeah.
So Steve Smolin, my brother, he's 8 years older than I, but his cancer presented in his 40s.
Wow.
So he was 48 and I was 40. And at that point, I started getting PSA tests when I was 40 years old. My PSA scores were below 0.5. I mean, they were hardly registering. But my doctor felt that was actually a very good thing to do because it made me vigilant. And so when the day came when, I'm hitting 52, 53, 54, and the PSA scores are starting to elevate, we started to really take very careful attention to the scores. And then later on, Charlie, and you can talk about this, the percentage, there's a percentage score, right? If it's over 11% or something, then
Of increase. Yeah.
that's another element of measuring prostate risk. But you asked about Gleason score.
Yeah.
And I am not a doctor, so I'm going to let you explain to your audience how that gets calculated. But the least of the Gleason scores, I believe, are 6. And so what he said to me is your Gleason scores are 6, 6, whatever. You have a 6, you have another 6, you have another 6. And that's based on the tumors that they pulled tissue out of and analyzed and said, you have an angioadenoma. I think that's what it's called.
Well, adenocarcinoma of the prostate. Yeah.
Okay, I mangled that. This
Right,
is
right.
why you went to medical school and I didn't. But they were all quote unquote wimpy, what he called wimpy cancer. And he said, so what we tend to do with that is we do a bunch of different things. And this is where that Zoom call came in the heat of COVID, when we're all locked up and I can't go anywhere. We're all masked up and whatever. And he starts throwing a ton of options at me. And I want to discuss what he said, and then maybe we can talk about it, because
sure.
One layer that I had, like you, I had an enlarged prostate, and it had gotten pretty bad. It had actually seized up at a point where I had to be catheterized. I couldn't pee.
Yep.
And that's not uncommon, guys. It does happen. And it's not pleasant, but at least, getting catheterized gives your bladder and your sphincter a chance to relax a little bit. So then you can pee again.
Yeah.
So I did have an enlarged prostate. It was getting uncomfortable. It was getting to a point where even certain medications to treat my allergies was causing it problems. Um, and what are they called? Norepinephrine drugs, where one
Right.
of the side effects is,
Yeah, exactly. The vasoconstrictors, they do something to squeeze it a little bit tighter. Yeah.
well, it was squeezing pretty tight.
Yeah. Yeah.
So
So go ahead. Go ahead. Yeah.
so we had this array of options. One is watchful waiting. I'm sure some of your viewers have heard that term. Um, I didn't consider that. Uh, yeah, he said we could also do selective placement of seeds that can get irradiated and irradiate the prostate, and then you become cancer free. Or you could do a radical prostatectomy. They do that with robotic surgery. And without further hesitation, I said, doc, I I've thought about this a long time. My brother had a similar type of surgery. He actually came down to Johns Hopkins in Baltimore and had the surgery in when around his 48th birthday, I believe it was. And I and he had an enlarged prostate too. And I said, you know what? I don't want to be chasing this the rest of my life.
Mm.
I've thought about this. I want to I want to see the day where I walk my daughter down the aisle and I have all these memories, and I want to have that to look forward to. I don't want to be thinking in the back of my mind I have to keep going to get prostate exams and biopsies and
Hmm.
perhaps have to deal with surgery after all. So I made a decision at that point to have um, robotic, they also call it cobotic surgery,
Mm.
which is robot assisted surgery. Um, and I decided to have that in December of 2022. I'm
Okay.
sorry, 2021, December 2021.
Okay. So just, I'm going to back up just a second and talk about that Gleason score.
Yeah.
And just also a disclaimer, Dan and I, we've talked, and he's given me permission to ask him anything. There's
Yeah.
no HIPAA.
No
We're not,
HIPAA.
no HIPAA involved here. So,
Right.
yeah. And so a Gleason score, when the biopsy is done, the pathologist looks under the microscope and gives the uh, the cells, or the sample, a score, and it depends on two parts of the biopsy in the section. They give it it actually, the lowest score is basically zero, where there's no abnormalities. There's no abnormalities, and it works itself up to a 6, which is a 3 on one side and a 3 on the other side. And a Gleason 6 is the so-called wimpy cancer, okay? And it's kind of the what Dan talked about, which is watchful waiting, is actually a treatment protocol called active surveillance. And in fact, Sloan Kettering now, they have more men enrolled in the active surveillance program than they do in the prostate cancer treated program. So a lot of men are electing to do the watchful waiting or the active surveillance with the Gleason score of a 6, which is considered a very early form of cancer, or almost just one above. When you hear a woman having ductal carcinoma in situ of the breast, it's really an encapsulated area, which is not in and of itself dangerous, but and similarly the prostate, that's with that score, is not considered dangerous. However, this is
Mhm.
the big asterisk here, and very big however. Every single individual case, every individual person, every individual man with a prostate who has prostate cancer is different. And in Dan's case, he had a Gleason 6, but with the family history that he had, that actually moves his risk of developing a more advanced cancer much greater. So,
Hmm.
Dan, lead us through now. This was diagnosed in 2020. You didn't have
Hmm.
your radical prostatectomy until December of 2021. So,
Right.
what was, what was going on? I know the pandemic was here, and that might have influenced certain treatments. But what was, what would, and actually I want to get back to the we'll talk about the prostate enlargement
Yeah.
after we get through this, because that I could talk all day about that from personal experience. But
Hmm.
yeah, but so what was kind of going on with, and again, making that decision again is an individual one, and certainly sometimes you just got to do what you have to do, so um
Yes.
yeah, so tell me about a little
So,
bit. Yeah.
so what was going through my mind at the time was a few things. Number one is that I had identified um, a place to be treated that I was very comfortable with, and that is the Shara Cancer Center at Inova Fairfax Hospital in Fairfax, Virginia. Really, truly
Hmm.
one of the best cancer centers in the United States. And my urologist at the time said, "Well, what do you want to do?" And I said, "Well, I've had a few more episodes with my enlarged prostate. It's driving me crazy. I'm also got a terrible sugar Jones, and that has me really concerned." And he kind of looked at me and said, "I've done my reading. I've done my reading. I know cancer loves glucose, and I'm craving it." Now, I don't know if that was me, Charlie,
Hmm.
but as I will tell you, as I got through past surgery, I didn't have the cravings anymore.
Hmm. Interesting.
So,
I don't doubt it. I mean, I don't look, it's not in the textbook, but I've heard, believe me, in over 30 years of practice, I've heard it all. And that's
yeah.
something I've heard. Yeah. I mean, yeah,
I
it's
mean, I would go
interesting.
through a bag of Milano cookies and want more. I mean, that was that bad. And I
Yeah.
was also risking myself for prediabetes because I was at a certain age, and your body does run down and is unable to deal with, as you said, as you get older, those difficult things.
Mm,
And I didn't want to become diabetic. And so I wanted to deal with this aggressively. I was having more situations where my prostate would seize up or it was difficult to pee. And it was bothersome. If I had to go on a long trip, I was
hmm.
making lots of stops, and it was, I'll tell you the funniest story. So
Yeah.
we went to an investment conference, my wife and I, and she goes, "I'm going to the bathroom. Why don't you go to the bathroom now?" And I get in line, and I'm there with a bunch of guys in their 70s and 80s who, probably have bigger prostates than I have. And I'm like, "Oh, guys, hurry up. I gotta pee."
Oh, God. Yeah,
So
well, I have to tell you, that reminded me of a funny story. Back in the day, when we go to Giant Stadium, or when the Giants used to play at the Yale Bowl or whatever, uh,
yeah.
people, guys would tell me, look, when you go to the bathroom, if you really got to go, especially if you had a couple beers, don't go in back of any man who has gray hair,
Right.
because you're going to be there for a while. And
Right.
so now that's me, right? Because it's going to take
Right.
me longer.
Exactly.
Yeah.
So I looked at all this stuff, and in the summer of, or is the spring of 2021, I said to my doctor, "Look," I said, "I'm committed to this. What I'd like to do is pick a date at the end of the year when I know my wife will be off and be able to care for me." And so that's what we did. So I picked December 21st, 2021.
Yeah.
Remember that date? It's all ones, twos, and zeros.
Yeah. Yeah.
And prior to that, about 2, 3 weeks prior, I had my pre-op appointments, and I got to meet my surgeon. And that was really breathtakingly wonderful.
Mm.
My surgeon is a woman. She was trained as an army doctor
Wow. Mm.
in doing trauma surgery in Iraq
Wow.
during the Gulf War. But she went to work at Walter Reed, and I forgot the name of the doctor who treated the Secretary of Defense, but
Oh,
she
right, right.
she worked with him,
Wow.
and her name is Inger Rosner. She's about 5 foot nothing,
Right.
has a wonderful sense of humor, and her entire team, except for one person, is women.
Wow.
I'll get into that in a minute because
Yeah.
that was astonishing.
Yes.
But she took me through the whole thing and she said, "What do you know about the surgery?" And I related back and I said, I I want to do this because I want to spare as many nerves as possible so that I can resume fairly good function post-op.
Yep.
But I also want to be done with this. I don't mind coming back and visiting you. You're a riot and you're a
Right.
lot of fun and you're really, really smart and I learn a lot from you. But I don't want to I want to know that I go through the surgery. I got a good chance that the prostate cancer is um, well encapsulated. I think the
Hmm.
term was you used.
Yep.
Um, they sew me back together fine, and I make a complete recovery.
Yeah.
And so that's the course
Sounds
of
like a
treatment.
good, yeah, that
And
sounds
that's
good.
the course of treatment that I decided to do. I had my brother Steve to counsel with. And now, mind you, he had the surgery in, when he was 48 years old. Here I am, I'm 60. So 12 years later
Yeah.
than he had it. So the surgery that was pretty cutting edge at Johns Hopkins in Baltimore 12 years before has now with cobots, which
Hmm.
are you can explain what that's about. Basically, Dr. Rosner sat at a station and operated these tools um, that were capable of precision movements
Yeah.
and different strengths and could do all sorts of really interesting things. So I looked at that and I'm like, you know what? The recovery is good from this. Um, I like this doctor. I think this is going to be really good. And I was like, let's do this.
Yeah. Yeah. That's, interesting now, uh, because you had cancer, okay,
Mhm.
you were living with cancer, okay, for almost 2 years. And the reason why Dan could do that again is because he had a type of cancer, the level of the cancer that was
Mhm.
at a stage where many men are doing the active surveillance. So basically, for those almost 2 years, he was undergoing active surveillance, but he had in his mind, which I think, and correct me if I'm wrong, but it probably gave you some peace of mind because you had a game plan. You knew what you were going to do. You weren't, kind of, oh, should I do this? Should I do that? And that's one, and you'll talk about that in a second. But
Mhm.
I've counseled patients over the years who have been struggling with making a decision, and they uh, they put themselves in a lose-lose position because what happens is they decide that they're going to do a procedure. And I'll give you an example. Let's say breast cancer. So you have
Yeah.
women who are told that they have breast cancer. It's an early stage, but they don't know what to do, and the doctor kind of advises them. And I know this because my wife had breast cancer, and
Mhm.
she elected not to be aggressive. And thank God that for her that was a good decision. But I've told patients, people over the years that if whatever decision you make, I'm not going to tell you what to do.
Mhm.
Whatever decision you make, you need to be all in. You need to be 100% all in. So, for instance, if you decide with a cancer to go for chemo,
Yeah.
don't kick yourself and say, oh my God, oh, I'm getting this chemo, it's killing all my good cells. Oh God, I'm waking up every morning. Oh, what body organ is going to be affected today?
Mhm.
Whatever. No, you don't do that. You're 100% all in. If
Yeah.
you make the decision not to do chemo or not to do an aggressive approach, you're 100% all in. So if you decide to do active surveillance, you're 100% all in. If you decide to do kind of a combination, a hybrid, if you will, with
Yeah.
like Dan did, he would active surveillance for 2 years, but knowing what he was going to do, then you do it. You're 100% with that. And to tell me, did that make, knowing that you had your mind made up, you knew what you were going to do, how did that allow you to live on a daily basis? Because having the diagnosis of the cancer, people are walking around. That's why, just kind of an aside, that's why we need to be
Yeah,
kind to people, because you never know
exactly.
what someone is going
You
through.
never
Yeah,
know. And I mean, we'll take my father. My
yeah,
father treated it so late in his discovery. I mean, my father was like John Wayne. He didn't let anything bother him until it got really bad. And
yeah.
they were treating him with a drug called Lupron,
Oh boy, yeah.
which shrinks your testes, actually
It's
reduces
chemical castration, basically.
your
Yeah,
bone density. I mean,
yeah.
he shrunk down, and I mean, my father was my height, and then
Mm,
he lost like 6, 7 inches in height,
yeah,
and he died with. I mean, he died from dementia and congestive heart failure and a few other things, but I am convinced it leached into his bones. He was always grabbing his backside and wincing in pain, and I was like, I choose not to do that
yeah,
to my wife, to my family, but most importantly to myself. I want to deal with this aggressively in a way that will, if I'm lucky, not involve chemo or radiation.
hmm,
And I'll walk out of the surgery and the recovery is going to be quick, and I'll get back to my life and it'll be smooth sailing.
yeah,
And
and
you're absolutely right. I was at peace with this.
yeah,
Absolutely at peace with this.
yeah, yeah, and it's not a, it's, as you know, you went through it. I mean, it's not an easy surgery, and it's a surgery. Now it's a little bit better, as far as the recovery, but still, there's potential side effects. You mentioned, sparing the nerves with erectile
Right.
dysfunction and incontinence, and all those as possibilities. In the past, those were almost a guarantee. Now, with the robotic surgery, they could, it, those nerves obviously are in. Well, let me back up and explain actually the anatomy of the prostate. And
Hmm.
we have our bladder, and women, the bladder, the tube that leads from the bladder out where you pee is very short. Okay.
Right.
In man, the tube that leads out of the bladder to pee has to go through the male organ, right?
Mhm.
But before it even does that, there's this walnut shaped structure called the prostate, which goes
Mhm.
wraps around it.
Yeah.
And that's where most of the semen is produced.
Right.
Okay. And the nerves for the erection, it goes right through that area.
Right.
So if there's, or right around it on the outskirts. So to do surgery to remove that and to spare those nerves has to be very, very delicate. And look, I mean, the reality is that human hands, you have the thickness of your hands.
Yeah.
So you do have fine tools, but you're limited. And in the back in the day, most men who had radical prostatectomies had significant problems afterwards. And
Wow.
fortunately, with the newer surgery, and it sounds like you had a crackerjack surgeon, which is unbelievable and great. And hopefully your post-op recovery and later on, you don't have to go into intimate details, but I hope
Yeah,
you,
well,
yeah,
I can describe a little bit. So I
yeah,
had the surgery on December 21st, and I think for a lot of guys when I talked to them, the biggest thing they were concerned about was being induced to general anesthesia. I'm terrified of having to count backwards and anything. I had none of that.
right.
What they do now is they give you a drug called propofol and put you to sleep,
Mm-hmm.
and then they give you the sevoflurane, I think it's called, inhalable medication, which is a paralytic,
Mm-hmm.
and you're on that so that you have no rigor in your body, and they can do things with less injury and get done with the surgery quicker. My surgery lasted about 3 hours and change. The and they make little incisions,
Mm.
little laparoscopic incisions. I had a total of six. And then I had a larger one, about 2 inches right above my belly button. It was that big incision that was where they would uh, put the excised prostate into like a mesh bag and pull it out, send it to pathology. And the rest of them were to put tools called trocars into my gut, and they'd fill up my peritoneum with gas so that they could see what they were doing. Interestingly enough, Charlie,
Yeah.
I told her before I went in, I said, you know, Dr. Rosner, I had a bout of diverticulitis in 2018. I got really sick. I ate something that had, something sharp on it, a bone fragment. It perched itself into my sigmoid colon and
Wow.
started bleeding. It
Ooh.
got abscess. I spent 5 days in the hospital. No surgery, but ended up having a colonoscopy afterwards. They found nothing. But because of that, I developed belly adhesions.
Mm.
And belly adhesions are, I guess, part of the healing process where organs that are healing somehow get stuck together on the abdominal wall. So
What's the
she told
scar
me,
tissue that does that from the
right,
surgery itself, kind of repairing it. It develops scarring and that kind of pulls it together. Go
yeah,
ahead.
well, the
Yeah.
scarring for me was from this perforation in my
Mm.
sigmoid colon. Okay. She said, "Oh, we'll clean that up." So the first thing that they do is they
Love.
look for any belly adhesions and they clean that up so that they can create as big a
Mm.
physical field as they can to operate so they can move the technology around, get a better view, do whatever. And so she said it was a textbook surgery, and I got out of it, 3 hours, came out of recovery at about 5.5 hours. I did not feel any pain. Now, I
Mm.
did ask for what's called a nerve block. Sounded good,
Right.
uh, but I didn't feel any pain really, even though they had me on Dilaudid afterwards, which was again as a precaution to make sure I didn't have any severe pain as a result, and I didn't need that much of it. And
Yeah.
um, I went home the next day,
Wow.
catheterized.
Yes.
Now, the
Yeah.
first thing they do in the surgery is they catheterize you. And then as you can explain how they remove the prostate, but they have to put you back together again. They have to rehook up the plumbing so that your urethra is now directly attached to your bladder. But
Yeah.
that went fine. Uh, you're going to have blood in the urine as a result of the surgery. That's normal, but it
Hmm.
wasn't terrible. And she came in on and checked on me a lot. And the great thing about the surgical team was they set me at ease.
Mm.
I went in, I went in completely confident of their care. They were thorough. Having a team of women surgeon and surgical assistants, I found to be breathtakingly wonderful. They
Mm.
were thorough. They explained everything, and they were exceedingly patient. And they would ask me if there's anything you didn't understand. I am happy to explain it to you again. I've rarely had, and I don't mean to besmirch all male doctors,
Yeah.
but some I think get a little impatient. And women who are in the medical profession, I have found, um, at least in my case, did a better job of putting me at ease. And a put at ease patient is probably going to have a better chance of recovery.
Hmm.
So the surgery is done in a very well confined part of this hospital. The prep room to the surgical theater is probably 40 feet, and then the surgical theater to the post-op unit is probably 50 feet,
Hmm.
and then probably another 20 to 30 feet to my hospital room.
Mm.
So if they needed to get me back into surgery, they could have done it very quickly, but I was a-okay.
Yeah.
And I was feeling pretty good. And by the time I got back to my hospital room, I was on social media telling everybody what had happened to me.
Right. I
And it was at,
remember. I
and it
remember
was at that point that I
that.
let the world know. Now you'll find this funny because you got a Jewish mother.
Right.
My mother says to me, "Why the hell are you telling the world
Right.
about this? It's nobody's business." I said, it is their business. I need to be an example to other men that this is very doable and I've had a great result. And I encourage you to be vigilant about your prostate care.
Hmm. Yeah, that's a good message. And yes, I could relate to that. And yeah, the interest of getting back to putting your patient at ease. I remember when I was
Yeah.
in my residency, and I was actually a medical student, and I
Mhm.
was rotating through the orthopedic doing my an orthopedic rotation.
Yeah.
And I had a great relationship with the head resident. He was a character, joked around with all his patients. We're wheeling a guy to the OR, and he goes to the operating room, and he goes to the guy on the stretcher as we're wheeling him. I'm at the head, and he's by the side, and he says, "You're not nervous, are you?" And the guy goes, "No." And he goes, "That's a good thing, because I sure am." I mean, it was all in good fun, but you don't really want to have that. There's a time and a place for that kind of thing. And yeah, I mean, he wasn't really nervous. He was just joking. But as far as I think that the women surgeons, especially when they're operating in urology,
Yeah.
are especially good, because they have to overcome a lot of barriers,
Yes.
especially in that field. So I think, it's now I'm just kind of thinking about it now. I never did before,
Yeah.
but I think that might be a good way to go,
Well,
because
yeah. And
yeah, hooray.
think about it. Inga Rosner, she's 5 feet tall, little thing. She she enlists in the army, I guess, to go to medical school. To that she didn't come from a lot of money, and she wanted to be a surgeon. And
Mhm.
so they sent her to Iraq, and she sees her share of trauma.
Wow,
And
yeah,
oh, this is the funniest thing. So Inova Fairfax is a level 1 trauma hospital, and she comes in to see me, and all of a sudden she starts hearing rotor wash,
ah, yeah,
and she starts freaking. I go, you okay? She goes, having a little flashback.
yeah, wow,
But
yeah,
think about what you just said. She gets trained in by Army doctors in trauma care. She gets specialized in urology. She goes to work at Walter Reed, the preeminent military hospital in the United States,
yeah,
very male oriented. And she's like number 2 on the urology team. And then she leaves and becomes the head of
wow,
urological surgery at Inova Fairfax Hospital,
yeah,
which is incredible. And
yeah.
what I will tell you is, I mean, before she wheeled me in, she's very gently stroking my shoulder. She'd go, "You're going to be fine." And I was like, that's all I needed to hear.
Yeah.
That's, sort of a mother's touch, but it was like,
Yeah.
we're going to be okay. So I remember being wheeled in, and I took a look at Marcia, who's white as a sheet, and what the heck's going on. And she said, "I've called all your family members to tell them you're okay. So how you doing?" I go, I'm kind of whacked out on Dilaudid right now, but I'm okay."
Right.
Um, but I got out of there the next day. And
Wow.
here's the thing that's really, really important. They prepared me for every drug I had to take,
Mm,
every anticoagulant I needed to
mm.
take, because there is a
Yep.
risk of blood clots.
Mm-hmm.
And so you have to do this injectable drug to
Yeah.
thin your blood so that you don't get blood clots. And there's antibiotics you have to take and other things. And if you do everything the way they tell you to do it, and just move around. Oh, that was the other thing. They were amazed at me, because the night of the day of my surgery, I'm going with my IV pole, and I'm doing circles around the ward. And they were like, "You'll get out of here faster." And I'm like,
Yeah.
I that's the other thing. When you have surgery, you got to keep moving. The reason why is they want your guts to be motile again. They want your intestinal tract to wake
Mm-hmm.
up, because until that happens, you're not going to be released from the hospital.
Yeah.
And I don't want to linger in the hospital. I wanted to get the heck out of there, and I did.
Yeah.
I
Yeah.
did
Well,
everything she told me to do.
yeah. And you did it. And a couple things. One is the confidence in your doctor
Mhm.
and having that positive mindset. Definitely. I mean, there have been, to me, it's common sense, but yes,
Yeah.
there have been studies to show that it does help. But to me, it's common sense. And when you're in a hospital, it's a cesspool in a sense of bacteria and
Uh-huh.
organisms and just a setup for getting an infection. To get your bowels working again, and uh, when you have to take narcotic
Mhm.
analgesics for pain and the anesthesia itself, that that causes your intestines not to work.
Right.
And that could be its own issue, especially when you're operating in an area of the prostate lower down. You
Right.
don't want to put any extra strain that might cause any sutures to come unloose or whatever.
Right.
And, so yeah, so Dan, it sounds like the surgery went well, the post-op, and a lot of that was the team and the confidence that you had in your team. That's wonderful.
Okay, now we got to talk about what comes next, Charlie,
Yeah,
because I want your audience to hear what perhaps is an inconvenience, but really was no big deal.
yeah.
And that is this: when they take that catheter out, you are not going to have any form of continence. So you got to wear depends,
Hmm.
and you have to do what are called Kegel exercises to strengthen um, the muscles in your perineum so that you can hold your bladder.
Yeah.
Now that took a little longer than I had hoped, but a little trick here. I actually went online and I found a product manufactured in Ireland.
Mm.
And essentially what it is it's a pair of jogging shorts with electrodes built onto them and a battery pack and a
Wow.
and something with a dial, and you follow the instructions. And what it does is it stimulates the Kegel muscles
Mm.
properly. Cost me
Wow.
about $400, and I'm like, geez, it's worth it. I did that for about 6 weeks, and the incontinence went away, and I was
Wow.
no longer wearing the pads. I was
Wow.
completely dry at night. Um, and uh, my scars were at the same time were healing very, very quickly. And she said that to me. She goes, "There's going to come a day you're going to have trouble seeing them."
Wow.
Now I got a hairy belly, so that kind of camouflages it. But
Mhm.
that was the only thing I had to deal with. But if you're willing to, there and afterwards I'll find you the box and I'll send you the information so that
Yeah.
you
Yeah.
can look it up and decide if you want to share this with your audience.
Yep.
But it's actually a product that was designed for women who have incontinence. But when I called the toll-free number, and I'm speaking to a woman in Limerick, Ireland,
Love
she has
it.
a lovely Irish accent.
Yeah.
And she says, "Oh no, we have men who do it here in the UK and in the EU, but it's not FDA approved. So you get this, you have to
Mm.
buy it from us, but you get this knowing that you can't expenses through, Anthem, Blue Cross Blue Shield or whatever. You got to
Right.
pay out of pocket for it." I said, "It's worth the $400 investment." And it
Yeah.
was.
Yeah. Wow. It sounds that way. I'm sure, your urologist probably, I'm sure you shared that with her. And that's something that could benefit because it's very hard when you have that catheter in, especially after the surgery. The bladder has its muscles. That's why uh,
Right.
the you can get a bladder outlet obstruction. It's called when you had a uh, when you were obstructed sometimes with the enlarged prostate driving, and when you took your allergy medications, it would
Hmm.
squeeze those muscles and close it down.
Yeah.
But when you have a catheter in there, it stretches it, and now those muscles are stretched. They're not working properly, and that's why you have the incontinence. But back in the day, men would have that permanently
Right.
because of the surgery, which is definitely discouraged men to get that because who would want that? You have erectile dysfunction, you'd be incontinent, and
Yeah.
it's pretty bad. What's worse, the treatment or the disease? I mean, look. cancer is cancer, and if you need it, you need it. But now the surgery is much better, and it sounds like you had a good post-op course, and yeah, I'd be interested in taking a look at that. Absolutely.
The technology they use in the surgical theater is developed by Intuitive Surgical, which is a big publicly traded company on the NASDAQ exchange. And we've since invested in it. Why? Because they're only in 3% of hospitals.
Mm.
And the feeling is that it can do surgery quicker, cheaper, and with less bad side effects.
Yeah. No slip, no slippy whoops, I mean,
Well,
no
I mean,
thick doctor hands,
you think about it,
Yeah.
they're using tiny little incisions with those trocars in your belly
Hmm.
to basically tie sutures.
Yeah.
And she's using this device with these thumb wheels. You can actually find lots of video online, Charlie, which shows the doctor manipulating these I don't know what they call them, the hand tools,
Yeah. Yeah.
and they can tie knots like they would in front of them
Yeah.
with
Wow.
perfect precision and whatever other measures they have to do. So I did not have post-op complications at all. If anything, and she said this, you had a perfect recovery.
Mm.
So I was thrilled by that. Now
Yeah.
let's get to the next step,
Yeah.
the biopsy.
Yeah.
So what did I tell your listeners and viewers about my Gleason scores?
Right. They were 6 initially.
Right.
Yeah.
Initially,
Yeah.
they were 7.
Wow. Yeah.
Now, could you describe what that means?
Yeah. Well, it means that the cancer is getting more, um, not looking like regular prostate tissue. So the higher the score, the more abnormal, the more pathologic the cells look. So you have a
Right.
regular cell, and a cancer cell looks a little bit different than the regular cell.
Mhm.
And as the Gleason score gets up and that it gets higher, and that's what the pathologist looks at, they get more deformed. And as they
Right.
get more deformed, they get more aggressive. It's almost like cancer likes to hide from the body's immune system. So it tricks the body. So initially it looks more like regular cells. So the immune cells come and they say, oh, this is just regular tissue. We're not going to do anything about it. But as the Gleason score gets better, as cancer gets more aggressive, it becomes more emboldened,
Right.
and it becomes more arrogant, if you will. And it says, we don't care. We're just going to look the way we look, and we're going to spread out our claws the way we're going to spread them out, and it doesn't matter. So 7 is kind of starting to get to the point where the cancer is getting closer to leaving the prostate.
Right.
And once that happens, it's a much uh, different scenario. And I'm going to talk a little bit about the different treatments and such in a little bit.
Right.
But the fact that Dan is saying they took it out and they found that, it means that yes, it was active surveillance that was going on with Dan, and they were watching him. But even with that, the cancer was getting worse. And
Yeah.
without definitive treatment, it's likely, especially with his family history, it would have been a much different scenario if he didn't act on it.
So the good news is the tumors were all well encapsulated.
Hmm.
Um, there was no suspicious tissue in the seminal vesicles, no suspicious tissue in the vas deferens,
Mm,
which is all gone. You know,
yeah.
so that's another aspect, which is no mess,
Yeah.
no more mess. So that's another thing to get used to. And but more importantly, um, within a couple of months, I had my first 3 months, I had my follow-up PSA score, and it was uh, non-detectable
Mm.
immediately. And it has been non-detectable now, um, you know, two
Yeah,
years
since
out,
then. Yeah,
two years out.
which is great. I mean, it's the fact that it was well contained and that is and that just
You know,
confirms it. What Dan was talking about, no mess in a way, that you take out the prostate, which I said is the predominant producer of semen. So
right,
sperm is made in the testes, and that goes up a certain pathway into the prostate, is mixed with the semen in the
right,
prostate and then ejaculate. So when
right.
there's no prostate, there's no semen, but there is still sperm, whatever. So,
Mhm.
but it's not it's different with the what men have to get used to in that regard.
Right.
It's different. So, well, that's it's the path that you took was getting definitive treatment. And as I said before, every individual case is different. Sometimes you just got to do what you have to do, and sometimes you got to go nuclear, and you just
Yes.
got to do it. And Dan made the decision, and making that decision again is so important, to be 100% all in, because that does so many things to the body. And I talk a lot about the automatic brain and our fight or flight. And when you're scared, and a lot of times fear is not making a decision, is not knowing, and putting yourself in a lose-lose. Whereas if you make one decision, oh my God, all these possible things can happen, so I'm going to make the other decision. Oh, but I make this other decision, all these possible things can happen. And you bounce back and forth. And with that indecision comes fear, comes the fight or flight, which suppresses our immunity and suppresses all the things that are good for us to give us the best outcome possible. And what Dan is talking about, what he did, and again, you find a good surgical team that you feel, and it's important to feel comfortable with the doctor
Yes.
also. Yeah, you might
Yes.
want to interview a few doctors, because you have to feel comfortable with your doctor. You have to have a doctor who is like Dan's team, surgical team, that was very caring, was very kind, was answering the questions. It's not their first rodeo, but it was Dan's first rodeo, and hopefully his last rodeo. So you want a team that treats you as though you're their only patient, and not a team that's not a doctor who's not going to answer your questions, not a doctor who's going to think your questions are stupid or whatever. Just, yeah, it's
And,
so
and,
important.
and let's face it, it is major surgery. This
Yeah.
isn't getting your tonsils out. This
Yeah.
is major surgery. They're basically reworking your plumbing. And that's why if if your viewers and listeners out there decide if they have gotten a positive diagnosis and this is the course of treatment for them, ask really good questions of your care provider. And if you don't feel comfortable, if your intuition is making you a little nervous, either ask more questions or get a second opinion, or perhaps even get a third opinion.
Yeah.
I will
Yeah.
say that at least within the United States in the major city areas, there's some really fabulous
Mm.
cancer centers that are top notch. We just happen to be very lucky in Northern Virginia to have a Nova. Um, and that's another thing that they're doing well, is that they have this massive cancer care center, which is basically where the urology department is based.
Yeah.
And so if they need to, they can bring in a radiological oncologist, they can bring in a nutritionist. They have all these resources now that were never available even 10 years ago.
Yeah.
So I feel like I dodged a bullet.
Yeah.
When she told me your Gleason, we had some 7 Gleason scores. They weren't all 7. They were a couple of 6, but there were a couple of 7, maybe
Hmm.
more. But I knew I had made the right decision. She looked at me and she goes, I know that you made the right decision as
Yeah.
well.
Yeah. Yeah.
And
So go ahead.
yeah,
Go ahead. Yeah. Yeah, I think so happy, obviously, you being a friend
Yeah.
this and this is really important. And so I want to go through now with
Mhm.
my audience. First of all, I'm going to talk about a little bit about prostate enlargement.
Mhm.
Okay, so benign prostate hypertrophy, BPH.
Mhm.
Most men, if not all men, are going to have BPH as they get older, 50s,
Right.
60s. Um, Most men actually by 80 to 90 are going to have small pockets of prostate cancer
Right.
that don't need to be treated. But BPH is very common, and I have it. It's a
Mhm.
pain, and so
Mhm.
there are different ways to treat it. Now,
Mhm.
I look, I've heard, and I know there was one occasion I never had the obstruction
Mhm.
and bladder outlet obstruction, which is due to what happens a lot of times when if you're on a long trip and your bladder is expanding. So you
Mhm.
picture, you're driving, you don't want to stop, so you put it off, you put it off, you put it off. If you had a large prostate, if you recall, I said that it's like a walnut that's
Mhm.
where the tube out of your bladder going out is that walnut is around it. If it's enlarged, it's pressing on it. Okay. Like you take a straw and you're pressing on the straw and you're trying to
Yeah.
suck through it or blow through it, you can't do it.
Right.
As that bladder expands, it closes up the opening of the bladder also. So it's it happened to me once that I felt that happening and I was in traffic and I
Oh,
couldn't get off to go and I was like praying and I was like screaming to get my mind off of it because it was so
yeah.
uncomfortable. Finally I got to a rest stop and I used biofeedback, and that's another technique that some centers have to help men with who are having this who are having low flow is focusing on the muscles and watching them open up. And the biofeedback actually puts electrodes in the area, maybe similar to the device using that similar technique
Mhm.
and focusing on the muscles to open it up. So I was able to open it up with that focus, but still it allowed me to get home and it was very uncomfortable. So what I've done, and you're going to find this interesting because I didn't want to take the medications that are prescribed. And the main reason I don't want to take the medications because doctors will, there's several like Flomax and Rapaflow and some others, and the doctors will tell you because there's a very uncomfortable side effect called retrograde ejaculation.
Yeah.
Okay.
Yeah.
And the doctors will tell you that, it doesn't, well, the drug reps will tell you, and then the doctors will tell you
Oh
that,
no, it happens.
it
It
does,
happened to me.
right, right. Oh, it doesn't happen.
Yeah.
Oh, 2% maybe. Well, it happens to almost every man. Some men,
Right.
it doesn't matter. Okay,
Right.
some it doesn't matter, and that's why they may not report it. But if it happened to me, if it happened to Dan, I can tell you it's happening. Okay, and
Yeah.
it's
Yeah.
uncomfortable, and meaning not to get too graphic, but you ejaculate, but nothing comes out, whatever, and it's an uncomfortable feeling. I didn't want to
Yeah.
have that, so I've gone all in with supplements. Okay,
Mhm.
with natural supplements, and I'll put them in the description what I'm taking, and it actually has helped me a tremendous. I don't get up anymore to go to the bathroom at night. I was getting up two, sometimes three times a night to go to the
Yeah.
bathroom. Not doing that anymore. So BPH is not prostate cancer. Okay. Um, some men, though, will have prostate PSAs that are 10, 12, 15, and they don't have cancer. It's due to the prostate is so large that the specific antigen is being produced. And so, what I would suggest, and this is not medical advice, but what I did in my practice was PSA that has been argued a lot. Okay. And you knew to do it, Dan, because you had a family history
Right.
and you did it. And I would always recommend my male patients to get at least once a year but there's a lot of studies now saying, oh, maybe men shouldn't be getting it. maybe it overdiagnoses, and the looking into it and the biopsies causes so many side effects. But this is a very good example of what happens when doctors don't wait, do as I say, not what I do. Okay, because they don't do that. So there was one of my cardiology colleagues once. He was a guy came into the hospital, and he was having a heart attack. It turned out the guy's uncle was the guy who wrote the New England Journal article about not doing catheterizations on acute MIs, but I forgot what the recommendation was, but it wasn't going right to the angio lab, the cath lab. It was watching them or doing something or giving them TPA. I forgot what the recommendation was, but he was saying don't do that. So my colleague, who graduated the same medical school that this guy did, who wrote the New England Journal, decided to call the guy up and say, look, I have your nephew here, and he's having this, event. And the guy, before he said it, so you're going to cath him, right? So you're going to bring him to the cath lab, right? I mean, he wrote the New England Journal article saying, don't do that. And the first thing was, are you going to do that? So I would suggest that men get PSAs when they're, I would say, 50 or over. Dan started earlier because of his family history. I think 50 or over is a good time. Certain ethnicities and certain racial groups, so they may want to start earlier because it seems to be a higher incidence in certain groups. So African Americans tend to have early onset prostate cancer, so I would say 45 and over for them. And every year, if you have a family history, certainly start earlier. And every year, and if you see that the frequency of increase is going up, and that's what Dan was talking about, the percentage increase over the year, that's something you want to monitor. And just because it's going up doesn't mean you have prostate cancer, but it means you need to do something. And you were talking about that, Dan. You said something about it started to go up at a faster rate.
Yeah, it did.
Yeah.
The PSAs were going up quite a bit,
Mm-hmm.
and that was alarming.
Yeah.
So, so I want a couple little wrinkles that can happen, and this just happened to be in my case. Early in my life, I had hair transplants. I had male pattern baldness, and one of the drugs they put me on to kind of stave off the hair loss is something called Propecia. And Propecia has it was an off-label indication to treat hair loss.
Yes.
And I'll let you describe what that is in a moment. But one impact of Propecia is that it artificially lowers your PSA score. So when you go off of it, your urologist is go, hey, whoa, hey, wait a minute, which is what happened to me. Propecia became extremely expensive, $400 a bottle, and I was like, this is crazy. I can't afford it.
Yeah.
So if you're also, like in the case of me when I was 40 years old treating hair loss, this drug called Propecia, which is the 1/5 strength version of something called Proscar, which is used to treat prostate cancer. Getting off of it suddenly does have an unintended side effect, and that is an increased level in your PSA score.
Yeah. Yeah. And that's because it blocks a receptor that for DHT, which is dihydrotestosterone. And so when talking about a little bit about the treatments for prostate cancer, one of them is chemical castration. So I mentioned before that I had a patient who had a castration. This was back in the early 80s. And now it's done more with chemicals, which take away any type of testosterone. So to shrink the prostate, taking away testosterone, but it has the effect that it's thought that testosterone or dihydrotestosterone can affect hair loss. And so blocking that causes some hair growth.
Mhm.
So it's, yeah, and it will affect the PSA. And that's one of the reasons why I don't want to do that. Some people, sometimes you have to though, every
Right.
case is different. And,
Right.
so you take a medication like that, like, Proscar or Avodart, and
Mhm.
so it works on shrinking the prostate. But there have been studies showing that men who are on those medications, when they're diagnosed with prostate cancer, sometimes it could be more aggressive because they didn't pick up the PSA elevation, which is another
Exactly.
reason to follow PSA even when you're not on it, because they're saying it does help detecting it early.
Right.
So you have all the information to make the decision. So Dan had a radical prostatectomy. Um, some men will elect for external beam radiation
Mhm.
or the seed implantation, which
Mhm.
is another form, which will, they want to spare the prostate. That's what they're
Mhm.
doing. They don't want to go through the surgery. Personally, if I was dealing with it, I probably would go through the robotic surgery,
Mhm.
personally, but the um, the external beam radiation has its own side effects, although it's gotten a
Mhm.
lot better, where they've been able to focus it. The brachytherapy, where they put in radioactive seeds in the prostate, which
Mhm.
had been very effective. It was actually, early on in the 90s, a lot of men would get that,
Mhm.
and it would cure them. Uh,
Mhm.
Actually, Rudy Giuliani, he was famously, when he was the mayor of New York, he had
Mhm.
that done. And so they said that he was cured for that. So he kind of made that, when he was the mayor, made that kind of in the talk. But it was a very common procedure. Proton beam
Mhm.
uh, therapy will is also, for certain types of cancers.
Mhm.
Prostate cancers can be effective, as the kind of another type of radiation therapy. Also, cyberknife therapy, and these are,
Mhm.
see, Dan had multiple locations of the prostate cancer.
Mhm.
When it's isolated, you could have one foci, meaning one location of prostate cancer. So a cyberknife, for instance, which is a radioactive stereotactic beam, goes right into that one area. That could be effective. But
Right.
again, it really depends on the type of cancer it is. Also, they're doing ultrasound, high frequency ultrasound,
Mhm.
HIFU therapy for some are doing that, for certain types of cancers of the prostate that are detected, that are local, and that are encapsulated.
Right.
I don't, I'm sure, did they talk to you about the external beam radiation? Did they talk to you about any other type of interventions?
Every therapy that you ticked off, we discussed.
Yeah.
And I was like, you're not listening to me. I got an
Right.
enlarged prostate. I want to get rid of it.
Right. Yeah. Right.
And I was, but I understand why they have to do it. They have to
Yes.
appear as if they're being um, dispassionate about the procedure, so that you have enough space to figure out what you want to do. Um, I'm glad I made the decision that I did, and I was wondering if I could talk to you about um, genetic risks.
Yes. Yeah.
Uh, so in post-op, I said to the doctor, I said, "Well, I'm 100% Ashkenazi Jewish, right?" And she lit up. She goes, "We got to get you in the BRCA test." Okay, so what that basically means is it's often the same gene that causes some forms of breast, uterine cancer, and can also cause prostate cancer.
Hmm.
Um, Not uncommon in Jewish populations such as the one I came from, Eastern European. So I did genetic testing, and I came up goose eggs, nothing.
Hmm.
And she said to me, and that's because there's a gene out there that you had that we haven't figured out yet.
Yeah. Yep. Yeah. I mean, obviously, there are some things that are familial. okay,
Yeah.
that just kind of run in families.
Right.
But when cells decide to turn cancerous, they're driven by something. And you were growing up in different areas and different, you may have been all in the same household when you were younger, but as you got older, you grew up in different areas and you were,
Mhm.
you weren't in the same household, exposed to the same environment and foods and whatever. So when you have such uh, a, a family that has the the history of the men in the family and prostate cancer, it's genetic. So,
Right.
there it will be found that there will be some gene mutation, that SNP they call them, that
Mhm.
is coding for certain proteins that somehow turn on and off the genes that are supposed to keep that prostate cancer at bay.
Right.
Um, so, what would happen is if it didn't keep it at bay, it can spread. And there's one other actually therapy I just wanted to mention that
Mhm.
I did recommend for a patient of mine once, which was cryotherapy, which is
Mhm.
freezing.
Right.
And the reason why I recommended it for him is because I knew the doctor who really was one of the leads on doing this kind of therapy, and he had a localized prostate cancer. I believe it was a Gleason 6,
Mhm.
but it was very close to the capsule of prostate. So when I say
Mhm.
the capsule, the prostate's here, it's right on the edge. If it gets out of the edge, then cells could enter into the lymphatics of the bloodstream and it could spread throughout the body. So it was very close. So I said that he really needed to have that taken care of. Even if it was a Gleason 6, I didn't feel comfortable with active surveillance because if it turned into a Gleason 7, like Dan's, where it was right on the edge. It could have kind of broken through the capsule. So he had the cryotherapy, which helped him. But some men, it spreads. And there are
Mhm.
chemotherapy is recommended for them. They don't recommend prostatectomy. They do recommend chemotherapy, sometimes radiation.
Mhm.
Um, and there's a new therapy which is called theranostics, and this is done in a few centers. And what it is a PET scan
Mhm.
that where a PET scan, where Dan talked about cancers love sugar,
Mhm.
right? A PET scan is basically a molecule of sugar that's radioactive, that is taken up by cancer cells. And when you do a PET scan, that's why um, when someone has cancer, they'll do a PET scan to see if anything's spread. It can light up because the cancer is taking up the sugar. Well, with theranostics, what they do is they attach a therapeutic to that
Mm.
sugar molecule.
Mhm.
So they use a PET scan to direct it toward the results of a PET scan to direct that molecule toward the cancer. So the cancer takes it up. And
Interesting.
so it's very localized. And that's an expanding area for cancer. And there are studies that are being done. I know Mass General is doing a study. I'm not sure if Memorial's doing it. I'm sure I think Johns Hopkins is as well. But though that's an exciting area also in this field. Um, with
I I I also want to well, as I said to you, and I said to my mother, I have to be an ambassador for this because what I've learned from Dr. Ignor Rosner is that men are presenting with prostate cancer younger than they have been historically. Men in their younger 50s
Mm.
and into their 40s. And she is treating a lot of patients surgically. She's doing 1,000 or more surgeries a year. That's a lot.
Wow, that is, oh my goodness.
That is a
Yeah.
lot.
And that's who you want to go to. If you need the surgery, you go to
That's
the
where you want to
doctor. Yeah.
go. Dr. Inger
Yeah.
Rosner.
Yeah. Yeah.
And so I said to her, what do you think is going on? She goes, we don't know.
Mm.
It could be anything and nothing at all. But this is why men have to get vigilant because it could be forever chemicals. It could be diet. or it could be genetic.
Mm,
In my family's case, I think it was genetic because, as you pointed out,
yeah.
there's a three generation through line.
Yeah.
Interestingly enough, my other older brother, he's fine. He didn't have any of this, but
Mm,
Steve and I had the exact same type of cancer and basically the same type of surgery and the same problems.
mm,
But why I'm doing what I'm doing, why I speak up, why I write about this on social media is because I I really want to show a brave face to men who, like you said, are their automatic brain is, I
yeah.
don't want to deal with this. Well, unfortunately, when you make believe it doesn't exist, it comes back and gets the last word.
Hmm.
And especially among my African American male friends.
Mm,
And I don't know how they've been touched because they don't talk about it.
yeah.
And men don't like to talk about prostate cancer. It is terrifying to them for whatever reason. You know, maybe it's how they view themselves as men, as virile men. I
Mm,
don't know.
yeah.
My attitude was different. I wanted to live to see my daughter walk down the aisle
Yeah.
and everything else in my life. I want to, I said to our shared friend Stu, I want to die laughing.
Yeah.
Yeah, I think that would be good. I don't want to die from some horrible disease. I want to die from a joke that is so
Right.
funny. I have coronary failure and, you know,
Right.
I have a heart attack and I'm gone.
Right. Yeah.
I
Well,
am
yeah.
very concerned about um, what Dr. Rosner said to me in the sense that the level of maybe it's just more diagnosis. I don't know.
Mm,
Maybe it's always been there and maybe more men are getting diagnosed. It's not really clear to her. There's a lot of anecdotal information, but nothing that can be called causal at this
mm,
point as to why this is increasing. But there's a lot to be concerned about, and men I think have to get, as you said, maybe get a prostate exam started earlier than they would normally do. Get that PSA plus the PSA free test earlier than they normally would. And this is perhaps the most important part. Sit down with your family members and ask about disease. Who got what and when?
hmm.
Did
Yeah.
anybody get prostate cancer? I just happen to know. I remember visiting my grandfather when I was 6 years old in Yale New Haven Hospital,
Yeah.
and that was like the first of the crude laparoscopic surgeries for prostate cancer. It was a difficult surgery for him. He
Yeah.
didn't recover well. I talked about my dad not doing anything until he had to do something, and it got very bad, and he probably died with it.
Mm,
You know. And then my brother Steve, who was very open with me, and I was actually at the hospital in up in Baltimore, you know, seeing him through post-op. So I had knowledge. Um, and it's important, I think, for your listeners out there, not only the men, but the women who care about them,
yeah.
to get knowledgeable about what prostate cancer means.
Yeah.
And if it has to be that wimpy cancer that we talked about is no longer called cancer, which I don't get, but if that's what it takes to get men to
Right.
the doctor, I'm all for it.
Yeah.
Right.
Yeah. Well, the new recommendations actually is that the doctors don't need to do the digital rectal exam to make a diagnosis. So digital rectal exam really doesn't need to be done anymore. It's all PSA, and there are other tests. There's a test called a PCA3, which the University of Michigan does, which is a little bit more sophisticated. It looks at some of the genetics in the urine, which can
Mhm.
somehow sometimes discern whether it's BPH or prostate cancer. But if there is if you're going to the doctor, I would say that it's important to go to the doctor and to get at least a yearly PSA, definitely over the age of 50. And for, as I mentioned, if you have a family history or African American, 45 or over, is certainly something you really should do. And you may be afraid to do it, but like Dan said, it's more fearful. The alternative, if you do miss the diagnosis, it's much worse. Um, but look, Dan, the fact that you made that decision early on and it was so definitive is so important. And I'm so grateful that that you did share this with us,
Yeah.
and came on the CoachMD podcast to do it. I really
Oh, anytime, Charlie.
do appreciate it. And um, any parting words that you want to leave us with to kind of your take home message? You've left a lot of take home messages, but if there's one that you can just leave for us today.
I would say that the state of care now is extremely good for prostate health. And I've been following this journey now for over 20 years since my brother was first diagnosed. And in each of those years, the medical community has gotten smarter and more sophisticated. And the tools available for them to do surgery are much more nimble and sophisticated. And oh, by the way, we're living in a time now, 2024, the year of AI. It would not surprise me that by the year 2030, the state of AI is going to be so good
Mm,
that a lot of cancers that may have been missed will be caught. And I'm not just saying prostate cancer, it could be any type of
yeah.
cancer. I think that we're going to be living in truly wonderful and remarkable times where diseases that would normally fell us young will be treated like a trip to the doctor.
Yeah.
And I will leave that, I will leave one thought, because you
Yeah.
and I shared a friend who sadly was diagnosed with pediatric leukemia
Mm-hmm.
while a camper. He was one of my peers and one of your campers.
Yeah.
And the state of treatment in the mid 70s,
Mm,
while sophisticated for the times, was rudimentary compared to what is being done now.
yeah.
Um, Unfortunately, he died at 16 years old.
Yeah.
He lasted a couple other years, but he died a terrible death. And now people that had the same diagnosis, but 50 years later, are leading normal lives.
Yeah. Yep.
So I would say to everybody listening and watching, ask really good questions of your care team. And if you don't understand something, find somebody who will explain it to you and tell you everything you need to do to make an informed decision. But be vigilant, because you got a life to live, and it's a wonderful life to live.
Yeah. Thank you, Dan. I really, really appreciate that. And thanks again for coming on. And I'm going to end our podcast today with my parting words. And you know me, Dr. Charles, aka Coach MD, urging you, every one of you, to stay strong in mind, in body, and right here in soul. Be well. Bye for now.